I'd like to talk about 5 specific EKG changes to look for in someone who's healthy or apparently healthy who comes in with syncope, and you've looked at the EKG and it's not great, they're not having an MI, it's not some abnormal rhythm. You're almost ready to say, it's normal, your EKG is okay. There are 5 things to specifically look for every time, every patient. And the way I like to think about it is, I look at the PR interval, I look at the QRS, and I look at the QT. And I'm looking for 5 things. The first is that PR interval very short? Is there a delta wave? Is this person going into a very fast tachyarrhythmia and having syncope due to WPW, Wolff-Parkinson-White, a pre-excitation syndrome? I look at the QRS. Is there big voltage? Is the QRS and the V leads touching one another? Those points from V2 are going from V2 to V1 or V3 to V2. Big voltage. Think about an obstructive cardiomyopathy, HOCM, IHSS, hypertrophic obstructive cardiomyopathy. As that heart starts pumping hard, patients have a syncopal episode because their outflow tract is blocked. Look for pulmonary hypertension, S1, Q3, T3. Not very sensitive for a PE. But if you see right-sided heart strain, you've got to be considering it. The next is something that gets missed. It's a cause of sudden death in up to 5% of patients who have no cause, and that is the Brugada syndrome. I'm going to show you that EKG momentarily, looking at it looks like a right bundle branch block or a funny right something in V1, V2, and then finally prolonged QT going into torsades, prolonged QT, ventricular ectopy, VTAC or VFib, cardiac arrest. This is an EKG example of Brugada syndrome. I put the arrow there, but look at V1, V2. They're grossly abnormal as compared to the rest of the EKG. If you don't look for it, the eye does not see what the mind does not know. So be thinking about these 5. I know there are other causes, but be thinking about these 5 and specifically rule them out. Thank you.